My next conversation in long form on YouTube is with Dr. Vikram Patel. I like to think of him as someone who is world famous in India. I have been an admirer of his work since I found out about this Goan organization that ran the Sangath Society for Child Development and Family Guidance back when I was in my 20s. And I wanted to start a similar center in Pune. They were one of the few teams with a multidisciplinary approach. They had speech and language pathologists, psychologists, and so on, and were focused on developing cost effective psychological treatments, which is the model of healthcare that I was attracted to and continue to advocate. Dr. Patel has since then played a pivotal role in shaping India's approach to mental health, contributing to the drafting of the country's first national mental health policy in 2014. He holds influential positions in government committees that develop the national mental health policy and also internationally at the World Health Organization. He's presently professor and chair of global health and social medicine at Harvard Medical School and co-founder of the movement for global mental health at the London School of Hygiene and Tropical Medicine. More popularly, he was listed in Time magazine's 100 most influential persons of the year. And he has many, many awards, accolades, honorary doctorates, and positions to his name, but is also one of the most down to earth psychiatrists that I know. I can go on, but I'm eager to talk to him. And I do hope that you enjoy this interview.
Good morning, Radhika.
Good morning, sir. It's so good to see you after so many years. The last time I remember being in my 20s, actually. I know we have limited time. So should I just straight away get
Yes, absolutely, Radhika. Please go ahead.
So I'll start with the first question now. This is something that I've been very, very interested in actually, and I know that you've written a lot about in India the vast need for mental health care, which clashes with a severe shortage of mental health professionals. In your papers, you've maintained that the scarcity hinders your traditional clinical interventions delivered by super specialists. So public health interventions is what you propose and utilizing trained lay counselors, which are crucial alternatives. I also read that you're a proponent of task shifting, so I know a lot about it now, and have championed bringing mental health care closer to communities at our doorstep. So, if I've read correctly, your vision underscores the vital role of highly trained specialists in providing supervision, capacity building, and support for this post. So, I'm eager to learn about your experiences with this model and what you call the healthy activity program. And if you could share some examples of how it has been implemented, or the successes it's achieved, or improvements that can be made, because I'd love to understand how we as professionals or as individuals can contribute to this approach if we resonate with its potential.
Well, thank you, Radhika. So first of all, to say, the question about the unmet needs for mental health, one that applies to all parts of the world. It's not just in places like India where we have very few mental health professionals. Take, for example, the US, which has more mental health professionals per capita than any other country in the world, yet up to 50% of people who are currently living with clinical depression have received no care at all in the previous 12 months. So I don't believe the question is only that of so-called developing countries. This is a universal challenge. And the reason for that challenge isn't only because we don't have sufficient mental health professionals, because the US has a ton of them, but it's also because people don't necessarily want to consult mental health professionals at all various moments of their lives when they may be struggling with their mental health. So we've got this kind of myth that's been built up, which is that the solution to the unmet needs for mental health care automatically means more mental health professionals. That is a solution that is not viable, and the US is an exemplar of that particular situation. So that's the first thing to say. The second thing to say is that mental health problems are not like a switch on and off. Either you have a mental health problem or you don't have a mental health problem. Anyone who works in the sector will know that there are stages of the evolution of mental health problems. There are, for example, many people who will have very mild symptoms for extended periods of time, and then for reasons because complex, many different reasons, they would then precipitate into a full-blown episode at some stage in the evolution of their illness. This means that a single size does not fit all.
Yeah.
You've got to tailor the approach to the specific needs of that individual. And this is where mental health problems differ dramatically, say, from many other medical conditions, let's say malaria, for example. In malaria, everybody who has malaria, regardless of their personal characteristics, will receive the same treatment. But that is not the case, say, for example, with a condition like depression. But what we've tried to do is to have a single one-size-fits-all model that works for many other medical conditions and assume that this is the model that applies to mental health. And of course, it does not. So with that in mind, the approach that we have really championed in Sangath, and now, of course, it's gone global, and I'll talk more about that in a moment, is to deploy frontline workers. These could be lay counselors, but it's not just lay counselors. It could be nurses, it could be peer support workers, it could be social workers, it could be community-based psychologists, essentially anybody who works at the front line where they are able to deliver a mental health intervention to people in need of that intervention in the moment. And typically, this requires you not only to have a very different way of thinking about the delivery of the intervention, but also what the intervention comprises. And by the latter, I'm referring to interventions that are usually very brief, that are designed around very specific active ingredients or components, for example, behavioral activation for mood problems, that do not require a formal diagnostic assessment, but actually rely largely on what the patient or the person who is struggling with their mental health describes is their need, and can be delivered in contexts that are convenient to the person who is struggling with their mental health. For example, a lot of my work is done either in primary care settings or even in individuals' own homes.
Oh, I didn't know
Absolutely.
that.
Well, think about it. If we are dealing with people who are struggling with their mental health, let's not forget many of these individuals also have very difficult social circumstances.
Yes.
And to ask them to come at a particular time to see the therapist in a hospital imposes enormous additional burdens, particularly on the poorest, particularly in those who live in disadvantaged or underserved areas, for example, in villages. So you will find very low uptake of those kind of traditional mental health services. And even if a person comes for one session, typically they will not follow up with you.
Yeah.
So how do you deal with these barriers that are really structural and social? Really go to the person rather than have the person come to you. Now, the healthy activity program that you mentioned is just a brand name for a behavioral activation treatment. It's a brief intervention, just 6 sessions long. Each session is about 30 to 40 minutes. You can do the math on how many hours of therapist time we're talking about here. Following the model I've described earlier, is delivered by any frontline worker. It is delivered in any setting that is convenient to both the therapist as well as the patient. And our trial showed not only very significant effects for people with severe depression in routine primary care settings, but you know what? 5 years later, a follow-up study has showed continuing sustained benefits to those who received this intervention compared to the control group. I don't think any psychosocial intervention has shown those long-term effects. I use the word psychosocial, and I want to emphasize the word social here. Another core aspect of the interventions we design is to recognize that social problems are bedfellows of mental health symptoms.
Yeah.
And to actually only focus, as many psychologists do, on the specific cognitive or behavioral features of a mental health problem, and to ignore, for example, domestic violence or the fact that someone is struggling with their financial situation, is essentially like treating TB by only treating the cough, but not the bacterium. It's not even a half solution, it's a non-solution. You really have to at least acknowledge the social world of the person who's struggling with their mental health. Finally, just to say about the Healthy Activity Program, this intervention has been replicated in a number of other settings in Nepal, in Uganda, but most excitingly for me, Radhika, it's now been reverse engineered for delivery in the US. And as we speak, this intervention that was designed in India, that was evaluated in India by an NGO working in collaboration with the state government, has now been re-engineered for delivery in the US and indeed also in Canada, making it probably the first time any health intervention which has been developed in India has actually been exported to the world's best resource countries.
It's amazing. Now, if some of us want to actually, enlist, how do we do that?
Well, so first of all, I want to say that this is not an intervention only for frontline workers who are defined by being non-mental health professionals. This is just as relevant for psychologists, for psychiatric social workers, indeed, any mental health professional. I can't speak for all clinical psychology training in India, but I can tell you the clinical psychology or psychiatric social work training that is available in India often includes a whole lot of theory, very little practical stuff. And
Yes.
even the practical stuff that people learn is like as if they're working in the US, where they're working in hospitals, they will learn complex cognitive behavioral therapies rather than interventions that are contextually appropriate, that have been designed for our context, for the people that we have to address on a day-to-day basis. Another good example is the Thinking Healthy program, which is for maternal depression, or we've got the PRIDE problem-solving treatment for adolescents with emotional disorders. All of these are contextually designed. They were designed for people in our context, and the training materials, the content, the manuals, etc., are all in local languages. Now, one of the things that we've been focusing on in the last 5 years is really thinking of how do we extend the training and supervision that is needed to master these treatments to scale. We can't do it through an NGO, we can't do it through a research mode. This is about doing things in a much more kind of almost like a business model, right? How do you take something that is working to scale? So a few years ago, we launched the Empower program. The Empower program is launched simultaneously in the US and in India. And it is intended to use a suite of digital technologies to enable people to learn these evidence-based treatments. For example, by having a competency-based digital curriculum for the treatment. But being good at psychotherapy is not just about learning a treatment online. There are many such initiatives around. What we also have is a suite of tools for assessing competencies, both knowledge and skills, as well as a suite of tools to enable groups of people who have learned this new treatment to form supervision groups. And those supervision groups can actually meet regularly online and use a suite of techniques, for example, audio recording sessions, listening to those sessions, rating those sessions, and providing narrative feedback as a way to master the delivery of those treatments. As we speak, our first scale-up effort in India is happening in the state of Madhya Pradesh, where in partnership with district health authorities, more than 500 ASHAs, who are frontline workers of India's national health system, have actually been trained in the Healthy Activity program. And I remember I saw the latest data from about 2-3 months ago. Of course, the numbers will have increased. They have now treated more than 2,500 individuals with severe depression in their communities with 90% treatment completion rates. Remember, 6 sessions of BA, 90% completion rates. I don't think most psychologists would see those kinds of completion rates in their clinics. And the same treatment adapted for the US is now being delivered in the state of Texas.
Wow. Is this limited to depression and anxiety?
So, with each treatment, each mental health condition has its own treatment, right? So, for example, my colleagues in Sangath are similarly doing work on autism. A 10-session intervention that is parent-focused called the PASS intervention is completing the largest evaluation using ASHAs as delivery agents in New Delhi state. And that is now going to be scaled up through a major Sangath program called Namaste, again, on the Empower platform. The third intervention is a step care intervention for adolescents in school settings who are struggling with emotional problems. This was the PRIDE program. And the fourth intervention is a peer support intervention for people who are struggling with serious mental illness. A couple of things that unite all of these is, first of all, that we only adopt interventions that are backed by robust evidence. By robust evidence, we mean multiple randomized controlled trials in which the intervention was delivered by frontline workers.
Is this in India? I mean, because
India or other low resource settings, because frontline workers have been mostly used in low resource settings. Second is the interventions have to have a clearly defined mechanism of change. So there has to be very robust, not only effectiveness based, but a very robust science base. The third is that the interventions are non-proprietorial, which means that there is no cost attached to actually, delivering the intervention. Many Western interventions tend to have, you've got to pay for it. You've got to pay for the manuals. You've got to pay for this, that, and the other. So we use only open access, non-proprietary interventions. And the fourth is that all of these interventions follow a certain kind of playbook of how do you learn, master, and then deliver these interventions by using the Empower platform as the backbone to that. We have 4 now which have met those criteria. The 5th that is in the anvil is a trauma-focused intervention, a single session peri-traumatic intervention. So this is almost a preemptive intervention for people. Let's say, for example, a person who has just been exposed to a violent criminal incident, or a person who has had a violence of any kind, an acute violence incident. How do you essentially provide that person a brief single session intervention that equips them with the necessary psychosocial skills to deal with the acute distress? And the idea really here is an intervention that can hopefully prevent a significant proportion of those individuals escalating into a more enduring mental health problem.
Are you also working with Anganwadis and Balwadis? I mean, I know you're working with Asha, but also...
True. Yes, we are. Thanks for reminding me. Actually, a 5th intervention I forgot was parenting interventions for early child development. The model I adopt for mental health is a very life course one. And we don't believe, the science clearly shows that the single most important risk factor for mental health problems that emerge usually in young adulthood are adversities in the first 2 decades of life. And so that begins from the day you're born. In fact, some would argue even during fetal life. But our efforts really begin during the earliest years of life through promoting responsive, stimulating parenting, the most evidence-based intervention to promote healthy child brain development, because this, we believe, is the first step in the pathway towards resilience and towards really equipping an individual with the capabilities to address the difficulties that every individual encounters in their life. I think we've mistaken the problem as stress. Stress is actually integral to the human condition, but we have tried to make stress the problem instead of recognizing that what we need is to build resilience. And resilience really is both an internal function, the capabilities of an individual to deal with difficulties, and that is then linked to these first 2 decades of life. And of course, resilience is also about the social scaffolding around a person's life, the social support networks, the opportunities that the person has for education, and so on and so forth. And so as a psychologist, as a provider, the latter can be hard to address because, these are things that are often in the political realm. But the former is what Sangath really emphasizes. How do you build the capabilities of a person from the earliest years to prevent mental health problems? And in later years, when they develop mental health problems, how to actually recover.
That brings me to my next question, where you've mentioned how clinical care can only be delivered effectively if there's a strong support from policymakers or an enabling framework for mental health policy. Now, in India, the Mental Health Care Act was introduced as this legislative framework to support people living with mental illnesses. And we know that this act has been recognized for its focus on human dignity, and a point which is highlighted in many of the Lancet Commission papers as vital for expanding your mental health agenda, sustainable developmental goals. Now, as someone who has been part of a family of caregivers and people living with mental illnesses, and who's also a practitioner, I had mixed emotions when I studied the act. And I asked myself first, how are we going to implement this? I mean, what do some parts mean 5 years now after its enactment? A lot of essential structures like mental health authorities and review boards are still not all there. So there's no oversight or accountability, and this hampers the act's effectiveness or scalability. As you've mentioned a lot, that there's a severe shortage of trained mental health professionals. So in the present Indian context, I would like to know your thoughts on the act and if these provisions are workable in our context, or what changes you might propose to make it more user-friendly or for us to eventually get there.
Yeah, well, Radhika, I am a huge supporter of the Mental Health Care Act. Let me start by saying that. I think the Mental Health Care Act was initiated by what who I consider probably was the single most important bureaucrat to champion mental health India has seen since independence, Keshav Desi Raju. And he followed an incredibly progressive procedure to develop the act. It was one of the most consultative processes that I know of. I don't know how many people were consulted, but it must surely number in the thousands across the country. And importantly, both professionals as well as civil society members, including people with the lived experience and families, were consulted. So make no mistake, it was developed with a lot of thought, a lot of care, a lot of respect. It also embraced some of the principles and values of mental health and human rights that had been embraced by the World Health Organization. So it was also fully aligned with the WHO and many other covenants to do with human rights. The second thing I want to say is that, we often talk about stigma and discrimination that people with mental illness face. We have to ask ourselves this question: why is there so much stigma? Why is there so much discrimination, fear, and shame attached to this? And oftentimes the go-to answer, particularly in the mental health professional communities, is that, oh, it's because people are uninformed. People don't know better. They believe in witchcraft, etc. And the solution to this is by educating people, having media campaigns, having celebrities talk about mental health. I beg to differ. My view is that the reason why stigma exists, not just in India, but all around the world, is because people with mental illness have been violated. They have experienced enormous levels of abuse, violence in every sector of society from times immemorial, and especially in the last 100 years in psychiatric care. You only have to look at the National Human Rights Commission report of 1999 that documents the terrible abuses that people with mental illness have faced in India's mental hospitals, most of which were built during the British colonial period, and most of which till 1999 had changed very little since 1947. The other important thing to say about the NHRC report was it wasn't initiated by professionals. It was initiated by civil society human rights activists. In other words, psychiatrists in the main were presiding over a hospital system that was largely colonial, custodial, carceral, and where the most awful abuses happened of people with mental illness without trying to reform the system. So think about this. Why would people not be scared of mental health care? Right. Why would people not shun mental health professionals if the lived experience of mental health care in society was one where you were locked behind the high walls of a building that was built 50, 70, 100 years ago, where you would most likely be naked for long periods of your time, where you would be in rooms that looked like jails, where you had no dignity, and where the form of treatment was primarily consisted of giving you heavy doses of sedative medication. And by the way, in many of these hospitals, ECT used to be given without a clinical indication, without anesthesia, and by the accounts of many individuals as a form of punishment. Wouldn't you be surprised if there would be no stigma? I often ask people, imagine if women with breast cancer were treated like this. Imagine if women with breast cancer were taken away by the police, taken away to a magistrate, forcibly incarcerated in a hospital that looked like a jail, forcibly given surgery without their consent. Breast cancer would also be heavily feared. So if we've got to remove the stigma from mental health problems, we've got to first reform our mental health care system. Yeah. And part of that is to bring mental health care closer to communities, to avoid using psychiatric labels that are associated with fear, shame, and stigma, to provide psychosocial interventions as the first line of care rather than a prescription, which is what most people experience, and to provide care that is tailored to the needs of individuals.
I agree. And what you say resonates so much with me simply because my grandfather was, I've heard stories, he was at Yeroda. Because that was the only place that they could take him. And my mother tells me he eventually died by suicide. She tells me of these harrowing tales of, the ECT and the hygiene aspects of the place. Not that I'm against ECT, but, the way in which it was administered and the way in which it all went about. So I understand what you're saying. And that kind of brings me to my last question about, concerning the suicide, very concerning suicide statistic in India. Now, we know that the WHO every year has published that almost 7 lakh people die by suicide. And India leads the suicide mortality rate, not just in the Southeast Asian cluster, but, internationally, of which young persons 15 to 29 or 30 and farmer suicides dominate all the literature that I'm reading. So we are falling short of the 2030 SDG target of reducing 8 standardized suicide death rates. And there are major challenges in suicide prevention, including I've read, the lack of a good national strategy, which I know is being worked on right now. In your opinion, what should the role of governments or NGOs or psychologists like us be, and what would you like to see in a policy, specifically the National Suicide Prevention Policy in India?
First thing to say, Radhika, is that it's really wonderful that there is a national suicide policy at last, led by Lakshmi Vijay Kumar and others. And so that's a long overdue. Suicide, it's important to remember, is a classic example of where mental health intersects with social issues. Classic example. And therefore, any policy that is seeking to address suicide is going to necessarily have to address both the social factors that are associated with poor mental health, as well as the mental health problem. So to answer your question, the role of psychologists is manifold, but primarily to ensure that people with the mental health conditions that are strongly associated with suicide receive evidence-based care. For example, severe depression, people receive behavioral activation. For example, people with alcohol-related problems, they receive motivational enhancement. Obviously, in the most severe end of many of these conditions, you often also need psychiatric care. So again, let's be clear, care that is tailored to the needs of the individual. But I think equally at the same time, we do need to acknowledge that many suicides occur in young people who are facing constraints on their opportunities and freedoms. You will not be surprised to hear that most suicides in India occur in young adults, and that unlike, of course, in the West, they mostly occur in older adults. In India, they occur in young adults. And I've done a very careful analysis of many of these suicides. In fact, the NCRB data also, has some kind of superficial analysis. Many of these young people are frustrated by social norms that constrain their lives. Our young people are growing up in a globalized economy. They can see the freedoms that young people around the world enjoy. And one of the most important of those freedoms is the freedom to love. Yet, we are giving our young people all the education, all the access to the internet and social media, and saying when it comes to the single most important freedom, you have no freedom at all.
It's very Shakespearean.
Well, exactly. And therefore, many young people choose to end their lives because they feel the life they want to lead is the life that they are being denied to lead. And this requires a structural social reform. What we're seeing in India right now is a further regression to medieval times, where instead of actually allowing even more freedoms to our young people, some of the conversations like love jihad remind me how rapidly India is slipping into a medieval world where the freedoms that young people are enjoying, like, for example, let's take China. China used to have the highest suicide rate in the world in the 1990s. Now it has a suicide rate that is half of India's. What explains this dramatic reduction in suicide mortality? It's definitely not mental health care. The single most important driver is women's emancipation. And in fact, what they tell you is that the single most important driver is that women no longer are chattel of their parents, that they actually have total freedom to choose where they live, what they do, who they marry, how many kids they have. They have total autonomy on their personal lives. And it struck me, this is the future of suicide control in India. We've got to change conservative social norms that are constraining, restricting, and ultimately destroying the lives of so many young people in India.
I think when you said autonomy, that resonates so much with what I've seen also in individuals who come to me for therapy. So that's something that I'm going to sit with. I know that you have to leave at 9, so I don't want to take any more of your time. Thank you very much for agreeing to do this today. I know you're busy, and I don't know if you've come to Goa just for work or for a holiday. And I know it's the end of the year, so I don't want to impose on you. Well, thank you, sir.
Thank you, Radhika. Bye-bye now.